Hello, everyone. This is Jamie Jessen. I'm a genetic counselor here at Impact Genetics. Thank you so much for the opportunity to review some of the retinoblastoma genetics basics and to talk a little bit about some future family planning, which is what the group I think was interested in talking about today. So I hope that you get a lot from this, and I'm going to record this and send it along so you can watch it later if you'd like. I know you've got a busy day there today. So what I'm going to talk about today is I'm going to go back to biology. I'm going to talk a little bit about the inheritance of retinoblastoma, the importance of testing within the family, and then some pregnancy diagnosis options. For those of you that might be getting into your family planning years, a lot of questions sort of come up at that time. So hopefully this is of help. So I think it's important to remember that our bodies are made of trillions and trillions and trillions of cells, and each cell has its own important function. They're all unique and different and interact in different ways. And each cell has a copy of all the genetic information within the nucleus of the cell. And that genetic information, or DNA, is structured into these units called chromosomes. Chromosomes contain tightly wound DNA, and if you stretch out DNA, you can see the DNA is actually what has all the genes that encode instructions to keep us healthy. So deoxyribonucleic acid, or DNA, that's the material that transfers all genetic information in all life forms. We have 2 copies of each of our chromosomes, and each chromosome, or all our chromosomes, contain about 30,000 genes. And genetic conditions occur due to mistakes in these genes. So we all have these genes, these healthy genes. It's not until we get mistakes, either inherit them or obtain them, that's when the problems arise. So when people say, oh, I have the breast cancer gene, that's incorrect. We all have the breast cancer gene. Just some of us have mutations in the breast cancer gene that make us risk for extra cancers in our life. So remember, we're equal halves of each of our parents. So each pair of chromosomes, again, contains its own set of important genetic instructions, and everything splits in half. Each egg gets half of mom's chromosomes, and each sperm gets half of dad's. And then baby comes together with an equal distribution of chromosomes from each of their parents. And this is random and happens randomly in every pregnancy. So again, these chromosomes are important. They contain everything that needs to keep us healthy. And you can see if you unravel the DNA, it's a real simple code, actually, that makes us these unique beings that we are. A, T, C, and G, those are the codes. That's exactly what all DNA is made from. And so it's these codes that really are the important pieces in terms of translating what the DNA is there for into proteins that actually make us healthy. So the DNA has one job, and each gene needs to be transcribed into a different type of molecule called RNA. And the RNA then produces the protein. And it's this protein that is the end result of a gene creating what it needs to create. And this protein can work by itself, or it can often work with other proteins that are created by other genes to keep us healthy and well. So damage to chromosomes can happen in a number of ways. Large damage, for example, you can see here there's a deleted piece of this chromosome. So this deleted piece of genetic information has important genes in there. So the remaining chromosome is missing a chunk of information, and so that you can understand that that would certainly have an effect. A duplication can happen where a piece of the chromosome is actually duplicated by accident. And the importance of knowing that the duplication can be just as detrimental as a deletion. We need just the right amount. And so that shows how specific genetic interpretation needs to be. One of the more common ways that genes can be deleted is just a single letter. So a typical healthy pattern you would expect to see, and sometimes we see a change in just one of those letters, and that can be enough to cause that gene to no longer create what it needs to create. So a simple example of that, if you looked at a sentence in a book and you really want to tell that person that you have a cat, so the function would be to say you have a cat. By changing the C to an R, you see that you have a completely different sentence, and maybe that doesn't make sense at all within this context. And so that's sort of how the genetic code works in regards to reading through them to decide, does this change actually make the gene not work? Or does it still make sense? For example, if it was 2 C's, it still says cat, but maybe it just doesn't function as well. So again, this code creates the function. So the sequence that's there is meant to create healthy functional proteins. Changes in the code can create either non-functional or slightly functional proteins, and that's really the basics behind genetic mutations and disease. Talking about cancer, all cancer is genetic. It's not all inherited. But cancer is not some foreign body that comes in. It's actually our own healthy cells that just over time, by chance, accumulate mutations in the genes that are important to keep the cell from growing out of control until there's so many mutations in genes that help control the growth of those cells, they don't know to stop dividing. And that's what cancer is. And whether you inherit this mutation from somebody that's in your family or you acquire it from various environmental factors or just through aging and natural human development, cancer is all genetic. It's just a matter of determining which genes are being damaged to cause that cancer. So one of the most important theories in terms of thinking about hereditary versus non-hereditary cancer, so the majority, 90% of cancers are non-hereditary, meaning they happen by chance. You inherit 2 healthy genes from each of your parents. And the first mutation happens by chance in 1 copy, but these cells are typically functioning just fine with 1 working copy. It's not until you obtain the mutation in the other copy that's when this cell no longer has control and develops into a cancerous cell. Hereditary cancer is different. That's when somebody actually either inherits or obtains a mutation in one of the copies of those genes that are important for cancer control. And so they really only require that second hit that's going to happen just as a matter of time and by chance, and they develop the same type of cancer. You can see these people are already 1 step ahead, which is why typically hereditary cancers can happen at earlier ages than cancers that happen from people that don't have a predisposition. The retinoblastoma gene is located on chromosome number 13, and it's what we call a tumor suppressor gene. Its job is just to control that those cells know when to stop dividing and when they are healthy or need to regenerate themselves again. So because it's on chromosome 13, that's a chromosome that is the same between men and women. If somebody has a mutation in one of the copies of their chromosome 13 genes, retinoblastoma gene, there's a 50-50 chance that they can pass along in each pregnancy. It doesn't matter if the person that has the disease is male or female, and it doesn't matter if the child is male or female. In this case, retinoblastoma is inherited in what we call an autosomal dominant fashion. So the types of retinoblastoma, again, are trilateral, quite rare. However, that's when we see both eyes affected and we also see a brain tumor. Bilateral retinoblastoma is when we see retinoblastoma that occurs in both eyes. And then unilateral retinoblastoma, and that's when we see just 1 eye affected with the cancer. Trilateral patients and bilateral patients, they are always these types of hereditary cancer patients. They have a mutation in one of the copies of the retinoblastoma gene in every single cell of their body. And so there's a 50% chance to pass this along to all their children, and they are at risk for lifelong secondary retinoblastoma cancers. So this is a given, regardless of whether you have genetic testing or not. That is a known fact. Bilateral retinoblastoma patients, so like that would be the index case, so the person that has the bilateral, again, has a 50-50 chance to pass this along to their children. And before genetic testing, we would say that the parents have quite a low chance to actually be carriers. This is if their parents are not already affected with retinoblastoma, and we know for certain have passed along that mutated gene. So if you have two unaffected parents who have a child with bilateral retinoblastoma, the chances of them having another child are actually quite low, 2.5%. The power of the genetic testing to be able to find that exact mutation in this patient's retinoblastoma gene offers a quick yes or no rule out test to all the relatives that are within the family. Unilateral retinoblastoma, this is a little trickier. The majority of these happen by chance. However, about 20% of unilateral retinoblastoma patients actually have a mutation in one of the retinoblastoma genes in either all or part of the rest of their body. 40% are what we call mosaic. So this means that they started off with two healthy copies of the retinoblastoma gene, and then as the embryo began to develop, a mutation was obtained during embryogenesis. So whichever cells of the body this cell are going to become will have the mutation, while the others will not. So that's sometimes why you can't find it in blood. Perhaps there is no mosaicism for this mutated cell line within the blood, but it might be other parts of the body. Retinoblastoma germline, unilateral retinoblastoma patients have traditionally about a 15% chance to be a carrier. They have about a 7.5% chance to give this to their children. And in this case, the unilateral patients, the chance that their parents are actually carriers are quite low, less than 1%. And so the sibling risk for those patients is about 0.4%. So 80% of the time, unilateral retinoblastoma patients are not carriers of a germline mutation. You can see that the mutations that are obtained within the retinoblastoma genes are just within the eye cells. So it's not something that's actually in their germline, something that happened by chance. Because of that small risk for mosaicism, so patients that have unilaterals that maybe they do have other cell lines that have that mutation, there is a small risk for future children, and so there is prenatal diagnosis that's available for these families. So you can see after genetic testing, this is testing of the blood of the unilateral patient. If we find that you do not have a mutation in your blood, it doesn't reduce the risk to 0 that you actually may have retinoblastoma mutations in other cells of your body. But now you've got a risk of about 0.5%. And so the risk to the future children are very low, not 0, but very low. And so this is why people may consider wanting to rule that out in their future children. And that's something that is absolutely available to those families. So the pregnancy testing options, first is nothing at all. Go along with a natural pregnancy and no testing within the pregnancy. And this is perfectly fine. We would say that if you are a patient that is going to have a child and either you or your partner have the bilateral form of retinoblastoma, we know there's absolutely a 50% chance risk. It would be important to consider inducing delivery a little bit earlier at 36 weeks and check the baby's eyes. The reason is between that 36 and 40 weeks is when we think those tumors can begin to grow. So by inducing delivery and checking baby for any tumors that may be there, catching them early will most certainly increase the chances that this child will not have an advanced retinoblastoma at the time of birth. And if they are clear of any tumors, then chances are they're not affected. And at this time, a blood sample can be taken from the baby and confirm for sure whether they have the mutation or not if their parent has already had the genetic testing. The CVS or amniocentesis are options within pregnancy. CVS is done between 11 and 14 weeks and has about a 1% risk for miscarriage. That's by using an ultrasound-guided needle that either goes through the abdomen or through the vagina. And they take a small piece of that placental tissue, because the placenta and the baby are made of the same cells, and check to see if the baby has inherited the retinoblastoma mutation or not. Amniocentesis is similar, done between 15 to 24 weeks. It has about a 0.5% chance risk of miscarriage. And that's by inserting, again, an ultrasound-guided needle that will take some of the amniotic fluid that the baby is living in. And that fluid contains sloughed off skin cells that contain all the genetic information from that baby and check to see if the baby is affected or not. Another option, and I always think this is an important one to consider, some patients do not want to put the pregnancy at risk for miscarriage by doing either of these invasive tests. But they'd like to know before the baby is born or before they induce delivery what the status is. So a late amniocentesis, that's done after about 36 weeks. There is no risk for miscarriage. And this allows you to be able to get a yes or no answer to whether the baby's affected or not, and to guide the decisions of, yes, baby's affected, let's get the induction going to make sure we take care of any tumors that might be developing, or no, baby's unaffected, and go along with your pregnancy. And again, all of these tests are possible only if we have found the mutation, the specific mutation in the retinoblastoma gene that that parent has. The IVF process is becoming, more and more common now. 1 in 4 couples experience infertility. So the IVF process, or in vitro fertilization, really involves ovarian stimulation using medication. And once the ovaries are stimulated, producing eggs, they are retrieved. And then the sperm is added for fertilization. And then once those embryos begin to grow, they are prepared for transfer. ICSI, or intracellular sperm injection, is a pretty common process, especially when doing IVF these days. And that is, instead of letting sperm sort of find their way into the egg naturally, the sperm are chosen by the healthcare provider and actually inserted into the egg. The thought is that this may produce a more viable embryo by choosing sperm that look the healthiest. It's not 100%, but it's oftentimes recommended as part of the process. So PGD, or pre-implantation genetic diagnosis, is done after IVF is completed and those embryos are growing. At about the 8-cell stage of when those embryos are developing, 1 cell is removed, and this cell is looked at under the microscope to see its viability, but then we also are able to perform genetic testing to see which embryos did not inherit the retinoblastoma mutation and which did. And so it would then be up to the couple to decide which ones to implant. PGD IVF, again, it's not an easy test to do. It is time consuming, it is expensive. But it is certainly an option for those parents and patients that would like to consider it, especially if a couple is having to go through IVF anyways because of fertility issues. The PGD process is really, from what I understand, is about $4,000 or $5,000 on top of that, which in the grand scheme of things is not that much compared to what you spend on IVF. But it is an option, and it's something that patients can consider. So the very best people, I think, in the world to talk to about these family planning questions and pregnancy options are genetic counselors, and the Canadian Association of Genetic Counselors are a wonderful resource to find counselors that are available to see you in clinic to discuss this. And this is a perfectly legitimate referral from a family doctor or any doctor just to say my patient would like to discuss prenatal diagnosis options, considering a family. Unfortunately, in some of our provinces, there's quite a long wait list, about a year, in some places even more. So it's something to think about to even get that going if you'd like to have that conversation. And again, I'm always available for those that may want to consider these options and have some questions, and of course, always available to you guys. And I hope that was helpful. Apologies for going quickly and for pausing. I've got a bad cough. So I hope this was of help, and I hope you guys have a wonderful day with each other. Okay, thank you.